This is Stephen Todman, pediatric cardiologist at LSU, and today we're going to be going over pediatric cardiac history and physical. So let's talk about gestational and natal history. Infections is something to ask about. You can have maternal rubella, particularly during the first trimester of pregnancy, that could result in multiple anomalies like particularly cardiac defects. Infections like CMV, herpes, and Coxsackie can be teratogenic if they occur in early pregnancy, and infections with these viruses later in pregnancy can cause myocarditis. HIV can be associated with infantile cardiomyopathy. Medications, it's important to ask about medications. Several are suspected teratogens: amphetamines, anticonvulsants, ACE inhibitors, valproic acid. All of those have been shown to be teratogenic, particularly causing different heart defects. But the one that I really want you to know is retinoic acid, because retinoic acid has a one-to-one relationship with conotruncal anomalies. So make sure you know the association between retinoic acid and conotruncal anomalies. We know that excessive alcohol intake during pregnancy can be associated with VSDs, PDAs, ASDs, tetralogy flow, and we have to be aware of fetal alcohol syndrome. And although cigarette smoking hasn't been proven to be teratogenic, it does cause intrauterine growth restriction. It's important to know that there's a high incidence of cardiomyopathy in infants born to mothers who have diabetes, and they have a higher incidence of structural heart defects as well. We should know that maternal lupus is associated with congenital heart block in offspring, and it's important to also know about birth weight. If an infant is small for gestational age, it can indicate intrauterine infections, rubella, those types of things. But particularly important is in infants with a high birth weight. They tend to have there's an association with infants with a higher birth weight with transposition. So if you have a baby who you're suspecting congenital heart disease and they're large for their gestational age, then you should really be thinking transposition, because although most congenital heart defects, if they're going to affect weight, are going to reduce it, the transposition is one where you'll actually see the birth weight increase. So that's a good association to know. So weight gain and general development can be delayed in infants and children with CHF or severe cyanosis. It's important to know that weight is affected more significantly than height in most types of congenital heart disease. And poor feeding of recent onset can be an early sign of CHF in infants, especially if the poor feeding is the result of fatigue and dyspnea. You also want to look for cyanosis, cyanotic spells, and squatting. And, the presence of cyanosis should be assessed just in general. And if the parents think that their child has cyanosis, then you should take it seriously. Parents know their kids best. The physician should ask the parent about the onset of the cyanosis. Was it at birth, several days after birth? The severity of cyanosis. Was it permanent or paroxysmal in nature? And also the parts of the body that were cyanotic. For example, fingers, toes, lips, and whether the cyanosis became worse after feeding. Evanescent acrocyanosis is normal in neonates, and you have to be aware of acrocyanosis, which is a benign condition. A cyanotic spell is seen most frequently in infants with tetralogy flow, although it's become less frequent because most surgical repairs are done in early infancy. And physicians should ask about the time of its appearance, for example, in the morning, on awakening, or after feeding. We should ask about the duration of the spells and the frequency of the spells. But most important is whether the infants were breathing fast and deep during the spell, or were they holding their breath, because this helps to differentiate between a true cyanotic spell and a breath-holding spell. The physician should ask whether the child squats when tired, because squatting strongly suggests cyanotic heart disease, particularly tetralogy of Fallot. Dyspnea, tachypnea, and puffy eyelids should also be looked for. There are signs of CHF. Left-sided heart failure is going to produce tachypnea with or without dyspnea, and tachypnea is going to become worse with feedings and eventually result in poor feeding and weight gain and poor weight gain. A sleeping respiratory rate of more than 40 breaths per minute is also noteworthy because a rate of more than 60 breaths per minute is abnormal even in a newborn. Wheezing or persistent cough at night could be an early sign of CHF. I've had a patient who was referred by a general pediatrician because they had the worst asthma the pediatrician had ever seen. They were on 4 different asthma medications, and they couldn't do anything about the asthma. When they came to see me, they just had all the classic signs of CHF. So just be aware that although wheezing most commonly is asthma, it may also be CHF. Puffy eyelids and sacral edema are signs of systemic venous congestion, and ankle edema, which is commonly seen in adults, is not found in children. So it's not found in infants particularly because ankle edema is dependent only if kids are ambulating. For babies who are on their backs, you're going to see sacral edema as opposed to this ankle edema. Frequent respiratory infections are also important to know about. Congenital heart diseases with large left to right shunts and increased pulmonary blood flow is going to predispose these patients to lower respiratory tract infections. And frequent upper respiratory tract infections, although they're not related to congenital heart disease, children with vascular rings may sound like they have chronic upper respiratory tract infections. Lastly, on this slide, I want to talk about exercise intolerance. Decreased exercise tolerance can result from any significant heart disease, including very large left to right shunt lesions, cyanotic defects, valvular stenosis or regurgitation, and arrhythmias. Obese children may be inactive and have decreased exercise tolerance even if they don't have any heart disease. So a good assessment of exercise tolerance can be obtained by asking questions like, does the child keep up with other children? How many blocks can the child walk or run? How many flights of stairs can the child climb without fatigue? All these are key in getting a sense of their exercise ability in a quantifiable manner. So to continue with the postnatal history, heart murmurs are important. If they're the chief complaint, then the physician should obtain information about the time of its first appearance and the circumstances of its discovery. Heart murmur heard within a few hours of birth usually indicates a stenotic lesion like aortic stenosis or pulmonary stenosis, AV valve regurgitation, or even a small left to right shunt lesion like a VSD or a PDA. Now, the murmur of a large left to right shunt lesion like a VSD or a PDA can be delayed because of slow regression of pulmonary vascular resistance. So it's not uncommon to have a situation where the newborn nursery writes down that the patient had no murmur, and then a couple of weeks later or a week later, they show up at the regular doctor, their pediatrician, and the pediatrician looks at the note that says no murmur, and they listen and they hear a very loud 3 out of 6 holosystolic murmur at the left lower sternal border, and they're like, wow, this is a huge, this is a PDA, and how could the newborn nursery have missed it? Well, they didn't miss it; it just wasn't present because it was because the pulmonary vascular resistance was high. So in the case of a stenotic lesion, the onset of the murmur is not affected by the pulmonary vascular resistance, and the murmur is usually heard shortly after birth. The heart murmur that's first noticed on a routine exam of a healthy-looking child is more likely to be innocent, especially if the same physician has been following the child's progress. And a febrile illness is often associated with the discovery of a heart murmur. Chest pain is another important aspect to think about when doing the postnatal history. It's a common reason for referral and parental anxiety. Many times patients will come in with chest pain, and the parents will be very concerned because they think that their 80-year-old mother had chest pain and she died of an MI. Well, the good news for pediatric patients is that it's very, very rarely the heart. If chest pain is the primary complaint, the physician want to ask whether the pain is activity related. So you want to ask, do you have chest pain only when you're active, or does it come even when you watch television? The physician also should ask about the duration, like seconds, minutes, or hours, and also the nature of the pain. Is it sharp? Is it stabbing? Is it squeezing? Does it radiate to other parts of the body, like the neck, left shoulder, shoulder or left arm, because chest pain of cardiac origin is not sharp. It manifests as a deep, heavy pressure or the feeling of choking or squeezing sensation. It's usually triggered by exercise. So the physician should also ask whether deep breathing improves or worsens the pain, because pain of cardiac origin, except for pericarditis, is not affected by respiration. Cardiac conditions that can cause chest pain include severe aortic stenosis, which is usually associated with activity, pulmonary hypertension or pulmonary vascular obstructive disease, and mitral valve prolapse can also cause chest pain. Although the chest pain and mitral valve prolapse can be more palpitation-based, and there's been a lot of doubt about the relationship between chest pain and mitral valve prolapse in children. So it's a pretty weak association. Less common cardiac conditions that can cause chest pain include severe pulmonary stenosis, pericarditis, Kawasaki's disease when there was stenosis or aneurysms of the coronary arteries. So that's important. Most children complaining of chest pain do not, though, have a cardiac condition. The three most common non-cardiac causes of chest pain in children are costochondritis, trauma to the chest wall or muscle strain, and respiratory diseases with cough, like bronchitis, asthma, pneumonia, pleuritis. The physician should ask whether the patient has experienced recent trauma to the chest or is engaged in activities that may have resulted in pectoralis muscle soreness. Gastrointestinal reflux and exercise-induced asthma are also other recognizable causes of non-cardiac chest pain in children. Exercise-induced asthma typically occurs 5 to 10 minutes into vigorous physical activities in a child with asthma or with inadequately treated asthma. It can occur in a child previously undiagnosed with asthma as well. A psychogenic cause of chest pain is also possible, and parents should be asked, whether there's been a recent cardiac death in the family, because that can often give patients a heightened awareness of these issues. Syncope, we know what syncope is. It's a transient loss of consciousness and muscle tone that results from inadequate cerebral perfusion. Dizziness is the most common prodromal symptom of syncope, and these complaints could represent a serious cardiac condition that may result in sudden death. It could also be due to non-cardiac causes like benign vasovagal syncope, dehydration, metabolic abnormalities, or neuropsychiatric disorders. Dehydration or inadequate hydration is an important contributing factor. A history of exertional syncope can suggest arrhythmias, particular ventricular arrhythmias, such as those that can be seen with long QT or severe obstructive lesions like severe aortic stenosis or hypertrophic cardiomyopathy. Syncope provoked by exercise that is accompanied by chest pain or without a history of unoperated or operated heart disease suggests potential cardiac cause of syncope. Syncope while sitting down suggests arrhythmias or seizure disorders, and syncope while standing for a long time suggests vasovagal syncope, which is often seen with dehydration. Hypoglycemia is a very rare cause of syncope occurring in the morning, and a syncopal duration of less than 1 minute suggests vasovagal syncope, hyperventilation, or syncope caused by another orthostatic mechanism. A longer duration of syncope suggests convulsive disorders, migraines, or cardiac arrhythmias. Family history is another important thing to think about. It should include coronary heart disease risk factors like MIs in family members younger than 30, cardiac arrhythmias, congenital heart disease, cardiomyopathies, long QT, seizures, and metabolic and psychological disorders. Palpitations. Palpitations is basically the subjective feeling of rapid heartbeats. And some parents and children are going to report sinus tachycardia as palpitations. Paroxysms of tachycardia like SVT or even single premature beats commonly cause palpitations. Children with hyperthyroidism should, if they have hyperthyroidism, it should be known that that could be a cause of palpitations, and pretty much anyone who has palpitations, you should be considering a TSH and a free T4. Joint symptoms is another important point. If it's the primary complaint, you got to think about acute rheumatic arthritis or rheumatoid arthritis, although the incidence has dramatically decreased in recent years in the United States. We want to ask about the number of joints involved, the duration of symptoms, whether it's migratory or stationary. Arthritis of acute rheumatic fever typically involves large joints, either simultaneously or in succession, with a characteristic migratory nature. Pain in rheumatic joints is usually so severe that the children refuse to walk, and a history of a recent sore throat or rash suggestive of scarlet fever can be helpful as well. The physician also is going to need to ask whether the joint was swollen, red, hot, or tender. Neurologic symptoms, a history of a stroke suggests thromboembolism secondary to cyanotic congenital heart disease with polycythemia or infective endocarditis. In the absence of cyanosis, stroke can be rarely caused by paradoxical emboli of a venous thrombus through an ASD. Although very rare, primary hypercoagulable state should also be considered, which includes conditions like antithrombin 3 deficiency, protein C deficiency, protein S deficiency, disorders of the fibrinolytic system, dysfibrogenemias, factor 12 deficiency, lupus anticoagulants. So a host of other conditions can cause secondary hypercoagulable states. So a history of headache can be a manifestation of cerebral hypoxia with cyanotic heart disease. Severe polycythemia or brain abscess can be seen in cyanotic children. And although it's claimed not to occur in adults, hypertension with or without coarctation rarely causes headaches in children, and choreic movement strongly suggests rheumatic fever. And lastly, medications. You want to ask about the name, the dosage, the timing, the duration of cardiac and non-cardiac medications. Medications certainly can be responsible for chief complaints of the visit or certain physical findings. Tachycardia and palpitations can be caused by cold medications or anti-asthmatic drugs. History of tobacco, illicit drug use could be the cause of chief complaints, and should be obtained preferably through a private interview with the child. You want to make sure you're taking a good family history. Things to consider are hereditary disease. For example, Marfan syndrome is often associated with aortic aneurysms or with aortic or mitral insufficiency. Holt-Oram syndrome, which is ASDs and limb abnormalities, is important to know about. Long QT, which predisposes to sudden death from ventricular arrhythmias. And idiopathic sudden death in the family should be inquired about. Pulmonary stenosis, secondary to a dysplastic pulmonary valve, is common in Noonan syndrome. And lentiginous skin lesions, Leopard syndrome, is often associated with pulmonary stenosis and cardiomyopathy. Congenital heart disease, the incidence is about 1%, or more specifically, 8 to 12 out of 1,000 live births. And of course, this doesn't include PDAs in premature infants, or it would be astronomical. A history of congenital heart disease in close relatives increases the chance of congenital heart disease in the child. So in general, when one child is affected, the risk of recurrence in siblings is about 3%, which is about a threefold increase. Having a child with hypoplastic left heart syndrome increases the risk of congenital heart disease in subsequent children to about 10%. And most centers are going to perform fetal echo at that threshold. Rheumatic fever frequently occurs in more than one family member, and there's a higher incidence of the condition among relatives of children with rheumatic fever. Although the knowledge of genetic factors involved in rheumatic fever is incomplete, it's generally agreed that there is an inherited susceptibility to acquiring rheumatic fever. And lastly, hypertension, atherosclerosis. Essential hypertension and coronary artery disease show a strong familial pattern. Therefore, when a physician suspects hypertension in a young person, it's important to obtain the family history of hypertension. Atherosclerosis results from a complex process in which hereditary and environmental factors interact. The most important risk factor for atherosclerosis is a positive family history with coronary heart disease occurring before 55 years of age in a father or grandfather, and before 65 years of age in one's mother or grandmother. So let's turn to the physical exam, particularly growth pattern. A growth impairment is frequently observed in infants with congenital heart diseases, and the growth chart should reflect height and weight in terms of absolute values and also in percentiles. That's pretty common now that we have electronic medical records. Accurate plotting and following of the growth curves are essential parts of the initial and follow-up exams of a child with significant heart problems. In overweight children, acanthosis nigricans should be checked in the neck and abdomen, and there's different patterns of growth impairment seen in different types of congenital heart disease. Cyanotic patients have disturbances in both height and weight. Acyanotic patients, particularly those with large left-to-right shunts, tend to have more problems with weight than with linear growth, and the degree of growth impairment is proportional to the size of the shunt. Acyanotic patients with pressure overload lesions without intracardiac shunts typically grow normally. And poor growth in a child with mild cardiac anomaly or failure of catch-up weight gain after repair of the defect could be due to failure to recognize certain syndromes, inadequate calorie intake, or the underlying genetic predisposition. So let's talk about inspection. A lot of information can be gained by just simple inspection without disturbing a sleeping infant or frightening a child with a stethoscope. Inspection should include the following: general appearance and nutritional state, any obvious syndromes or chromosomal abnormalities, color, particularly cyanosis, pallor, or jaundice, clubbing, respiratory rate, dyspnea, retraction, sweat on the forehead, and chest inspection. General appearance and nutritional state, you want to note whether the child is in distress, are they well-nourished or undernourished, happy, cranky. Obesity should also be noted. Besides this being associated with other cardiovascular risk factors like dyslipidemia, hypertension, and hyperinsulinemia, obesity is also an independent risk factor for coronary artery disease. Chromosomal syndromes, you want to understand that obvious chromosomal abnormalities are known to be associated with certain congenital heart defects. For example, 40 to 50% of children with Down syndrome are going to have a congenital heart defect, and the two most common defects are endocardial cushion defects and ventricular septal defects, with endocardial cushion defects being more common. And a newborn baby with trisomy 18 virtually always is going to have a congenital heart defect. So now I'm going to talk about different syndromes, the first one being Alagille Syndrome. It has a frequent association with cardiovascular anomalies, about 85%, most commonly peripheral branch pulmonary artery stenosis with or without complex cardiovascular anomalies. The major features are deep-set eyes, as you can clearly see, broad forehead, long straight nose with a flattened tip, prominent chin, small low-set ears. There's a paucity of intrahepatic intralobular bile ducts with chronic cholestasis in 91%, so that's definitely one to remember. You can have hypocholesterolemia, butterfly-like vertebral arch defects seen in about 87% of patients, growth restriction, mental retardation, and the etiology, it should be known that it's autosomal dominant and in 22q11. Charge association is another important genetic association to know about. From a cardiovascular perspective, there are going to be abnormalities in about 65% of patients, and these abnormalities can include tetralogy of Fallot, truncus arteriosus, aortic arch anomalies like vascular rings or interrupted aortic arch, conotruncal anomalies particularly. The major features are coloboma, heart defects, choanal atresia, growth or mental restriction, GU anomalies, ear anomalies, genital hypoplasia, and the etiology is a defect in 8q12, or particular deletion in 8q12. Carpenter's syndrome is another disease that you should know about. From a cardiovascular perspective, it frequently has cardiovascular issues like PDAs, VSDs, pulmonary stenosis, and transposition. Major features include brachycephaly with variable craniosynostosis, mild facial hypoplasia, polydactyly, and severe syndactyly, and the etiology is that it's autosomal recessive. And you can see to the right, you see an example of brachycephaly and significant severe syndactyly and polydactyly. Here we see an example of Cockayne syndrome. From a cardiovascular perspective, you can see accelerated atherosclerosis, and the major features are senile-like changes beginning in infancy. They're small, they have microcephaly, they have a prominent nose and sunken eyes, they have retinal degeneration and hearing loss, and you can see some images to the right. The etiology is autosomal recessive. Next is Cornelia de Lange syndrome. From a cardiovascular perspective, about 30% have cardiac issues, most commonly VSDs. The major features include synophorus, which is the eyebrow findings. They're hirsute. They have prenatal growth retardation, microcephaly, anteverted nares, downturned mouth, and mental retardation. And you can see a picture to the right. The etiology is unknown, although it's believed to be at least in part autosomal dominant. The next syndrome is Cri-du-Chat. It is a deletion of 5p, and cardiac manifestations are not frequent, only about 25% of the time, and they are most commonly VSDs, PDAs, and ASDs. The major features are this cat-like cry in infancy, microcephaly, and downward slant of the palpebral fissures that you can see in the picture to the right. And the etiology is a partial deletion of the short arm of chromosome 5. Crouzon's disease, or craniofacial dysostosis, is another genetic syndrome you need to know about. From a cardiovascular perspective, you can see VSDs and coarctations occasionally. The major features are ptosis with shallow orbits, premature craniosynostosis, and maxillary hypoplasia. All of these you can see in our image to the right, and the etiology is autosomal dominant. DeGeorge syndrome is next, and there are frequent cardiovascular anomalies, most commonly conotruncal issues like interrupt aortic arch, truncus arteriosus, tetralogy of Fallot. There can also be VSDs and PDAs. The major features are hypertelorism, short philtrum, down slanting eyes, hypoplasia or absence of the thymus and parathyroid. There can be hypocalcemia, deficient cell-mediated immunity, and the etiology is it's a microdeletion of 22q11. Down syndrome is next. They have frequent cardiovascular issues. About 40 to 50% of the time, they'll have cardiovascular issues, most commonly endocardial cushion defects, yet they can also have VSDs. The major features are they can be hypotonic, they have flat faces, slanted palpebral fissures, small eyes, mental deficiency, they have a simian crease, and the etiology is, of course, trisomy 21. Ehlers-Danlos frequently has cardiovascular issues, most commonly ASDs, aneurysms of the aorta, and carotids. They can have intracranial aneurysms and mitral valve prolapse. The major features are hyperextensive joints, hyperelasticity, fragility and bruisability of the skin, poor wound healing, and it is autosomal dominant. Ellis-Van Creveld is next. It has frequent cardiovascular manifestations, most commonly ASDs and single atrium, so make sure you know that. The major features are short stature, which is of prenatal onset, short distal extremities, narrow thorax with short ribs, polydactyly, nail hypoplasia, and neonatal teeth. So we have some pictures to the right to help you remember that, and the etiology is that it's autosomal recessive. Fetal alcohol syndrome is occasionally linked with cardiovascular anomalies, most commonly VSDs, PDAs, ASDs, tetralogy of Fallot. The major features are prenatal growth restriction. They have microcephaly, short palpebral fissures. They have mental deficiency, and they're often irritable or hyperactive. And, of course, the etiology is ethanol ingestion. Fetal warfarin syndrome occasionally has a predilection for the heart. You can see tetralogy of Fallot, VSDs. The major features are facial asymmetry and hypoplasia. You can see hypoplasia or aplasia of the pinna with blind or absent ear canals, which is microdia. Ear tags, cleft lip and palate, epitubular dermoids, hypoplastic vertebrae. And the etiology, of course, is warfarin exposure. Certain organ system malformations have a high predilection for cardiac defects. Ones that I pay particularly close attention to would be TE fistulas or esophageal atresias, which have a 21% frequency for particular cardiac defects. Omphalocele, 21% versus gastroschisis, 3%. Bilateral, unilateral renal agenesis, as well as horseshoe kidney, is also above 15%. Anorectal anomalies, 22%, and perforate anus, 12%. Diaphragmatic hernias, agenesis of the corpus callosum, all of those organ system malformations should make you think, should I order an echo to better assess any congenital heart defects that might be present. Okay, let's unpack inspection a little bit more, and we'll start with color. The physician should note whether the child is cyanotic, pale, or jaundiced. In cases of cyanosis, the degree and distribution should be noted. For example, is it throughout the body, only on the lower or upper half of the body? Now, mild cyanosis is difficult to detect, and the arterial saturation is usually 85% or lower before cyanosis is detectable in patients with normal hemoglobin levels. Cyanosis is more noticeable in natural light than in artificial light, and cyanosis of the lips can be misleading, particularly in children who have deep pigmentation. The physician should also check the tongue, nail beds, and conjunctiva. When in doubt, the use of pulse ox is confirmatory. Children with cyanosis do not always have cyanotic congenital heart defects. Cyanosis can result from respiratory diseases or central nervous system disorders. Cyanosis that's associated with arterial desaturation is called central cyanosis. Cyanosis associated with normal arterial saturation is called peripheral cyanosis. So if there's arterial desaturation, it's central cyanosis, and if there's normal arterial saturation, it is peripheral cyanosis. And even mild cyanosis in a newborn requires thorough investigation. Peripheral cyanosis can be noticeable in newborns who are exposed to cold and those with congestive heart failure, because in both conditions, peripheral blood flow is sluggish, losing more oxygen to peripheral tissues. Cyanosis is also seen in polycythemic patients with normal oxygen saturations. Circumoral cyanosis, which is cyanosis around the mouth, is found in normal children with fair skin. And isolated circumoral cyanosis is not significant. Acrocyanosis is a bluish or red discoloration of the fingers and toes of normal newborns in the presence of normal arterial oxygen saturation. Pallor can be seen in infants with vasoconstriction from CHF or circulatory shock, or in severely anemic infants. Newborns with severe CHF and those with congenital hypothyroidism may have prolonged physiologic jaundice. PDAs and pulmonary stenosis are common in newborns with congenital hypothyroidism. Hepatic disease with jaundice can cause arterial desaturation because of the development of pulmonary arteriovenous fistulas. Another name for that is arteriohepatic dysplasia. Now, clubbing, and you can see a picture of that on the right, is essentially long-standing arterial desaturation, usually more than 6 months before you actually, will see this clubbing. It results in, you can have it with the fingernails and the toenails, and when fully developed, clubbing is characterized by a widening and thickening of the ends of the fingers and toes, as well as by convex fingernails and loss of the angle between the nail and the nail bed. You can see reddening and shininess of the terminal phalanges, and that's the earliest stages of clubbing. Clubbing appears earliest and most noticeably in the thumb, and it can be associated with lung disease like abscesses, cirrhosis of the liver, subacute bacterial endocarditis, and occasionally clubbing occurs in normal people like in familial clubbing. Respiratory rate dyspnea and retractions is next, and the physician should note the respiratory rate of every infant and child. If the infant breathes irregularly, the physician should count for 1 entire minute. The respiratory rate is faster in children who are crying, upset, eating, or feverish, and the most reliable respiratory rate is that taken during sleep. After finishing a bottle of formula, an infant can breathe faster than normal for 5 to 10 minutes, and a resting respiratory rate more than 40 breaths per minute is unusual, and more than 60 breaths per minute is abnormal at any age. Tachypnea, along with tachycardia, is the earliest sign of left-sided heart failure, and if a child has dyspnea or retractions, this could be a sign of more severe left-sided heart failure or significant lung pathology. Next is sweat on the forehead. Infants with CHF often have a cold sweat on their foreheads, and this is an expression of heightened sympathetic activity as a result of compensatory, essentially it's a compensatory mechanism for decreased cardiac output. Acanthosis nigricans is a dark pigmentation on the skin creases, most commonly seen in the neck and in the majority of obese children and those with type 2 diabetes. It's also found in the axilla, groin, inner thighs, and in the belt line of the abdomen. Rarely, acanthosis occurs in patients with Addison disease, Cushing's syndrome, PCOS, hypothyroidism, hyperthyroidism, and this condition is associated with insulin resistance and a higher risk of developing type 2 diabetes. So last is inspection of the chest. A precordial bulge with or without actively visible cardiac activity suggests chronic cardiac enlargement. Acute dilation of the heart does not cause a precordial bulge. Pectus carinatum is when the sternum protrudes on the midline. It's usually not a result of cardiomegaly. Pectus excavatum is this depression of the sternum and rarely, if ever, causes significant cardiac issues. It can be a cause of a pulmonary systolic murmur or a larger cardiac silhouette on an AP view of the chest. For chest x-ray. As a group, children with significant pectus excavatum have a shorter endurance time than normal children. And Harrison's groove is the last thing I want to talk about. It's a line of depression on the bottom of the rib cage along the attachment of the diaphragm, and it indicates poor lung compliance of long duration, such as that seen in large left-right shunt lesions. Okay, let's turn to palpation. Palpation should include the peripheral pulses, their presence or absence, the pulse rate, the volume of the pulses, and the precordium, which you want to see the presence of a thrill, the point of maximal impulse, the precordial hyperactivity, and normally palpation is going to follow inspection. So let's turn to the peripheral pulses. The physician should count the pulse rate and note any irregularities in the rate and the volume. The normal pulse rate is going to vary with the patient's age and status, and the younger the patient, the faster the pulse rate. Increased pulse rate can indicate excitement, fever, CHF, arrhythmia. And bradycardia can mean heart block, effect of drugs, and so on. Irregularity of the pulse suggests arrhythmias, but sinus arrhythmia, which is an acceleration with inspiration, is normal. So don't be tricked by that. And also, if your pediatric cardiologist writes down sinus arrhythmia as a reading of EKG, please don't refer that patient because sinus arrhythmia is normal. The right and left arm and an arm and a leg should be compared for the volume of the pulse, and every patient should have palpable pedal pulses of the dorsalis pedis, tibialis posterior, or both. It's often easier to feel pedal pulses than femoral pulses, and attempts at palpating a femoral pulse often wake up a sleeping infant or upset a toddler. If a good pedal pulse is felt, coarctation of the aorta is effectively ruled out, especially if the blood pressure in the arm is normal. Weak leg pulses and strong arm pulses suggest coarctation, and if the right brachial pulse is stronger than the left brachial pulse, the cause can be a coarctation occurring near the origin of the left subclavian or supravalvular aortic stenosis. A weaker right brachial pulse than a left suggests an aberrant right subclavian artery arising distal to the coarctation. And bounding pulses are found in aortic runoff lesions like PDAs, aortic regurgitation, large systemic arteriovenous fistulas, or persistent truncus. Pulses are bounding in premature infants, particularly because of their lack of subcutaneous tissue and because many of them have PDAs. Weak thready pulses are found in cardiac failure or circulatory shock or in the leg of a patient with a coarctation. And a systemic to pulmonary shunt, like a classic BT shunt or a modified BT shunt, or subclavian flap angioplasty for repair of a coarctation, can result in an absent or weak pulse in the arm that was affected by surgery. Arterial injuries resulting from previous cardiac catheterizations can cause a weak pulse in the affected limb as well. Pulsus paradoxus is suspected when there is a marked variation in the volume of the arterial pulses with the respiratory cycle. And the term pulsus paradoxus doesn't indicate a phase reversal. Rather, it's an exaggeration of the normal reduction of systolic pressure during inspiration. When arterial blood pressure is being monitored through an indwelling arterial catheter, the presence of pulsus paradoxus is easily detected by a wide swing, which is greater than 10 millimeters of mercury in arterial pressure. In a child without arterial pressure monitoring, monitoring, you need a blood pressure cuff. And pulsus paradoxus can be associated with tamponade, secondary to pericardial effusion, or constrictive pericarditis, or it could also be due to severe respiratory difficulties seen with asthma or pneumonia. And it's also seen in patients who are on ventilators with high pressure settings, but in these cases, the blood pressure increases with inflation. So the presence of pulsus paradoxus is confirmed by the use of a blood pressure cuff, and I want to go over how you do this because tamponade is a clinical diagnosis. So you can see on this chart, first you're going to raise the cuff pressure about 20 millimeters of mercury above the systolic pressure, and then you're going to lower it slowly until you hear the first crot cough sound for some but not all of the cardiac cycles, and the reading is noted, and that's going to be your A line. So when you first hear your crot cough sounds, that's your A line. Okay, you can hear it for expiration but not inspiration, expiration but not inspiration. So you make note of A. Then you keep lowering the blood pressure until the systolic sounds are heard for all cardiac cycles, and the reading is going to be noted for B. So after that, you just subtract A from B, and if your number is greater than 10 millimeters of mercury, then your patient has pulsus paradoxus. So let's talk a little bit more about palpation. A person should palpate the following on the chest. They should palpate the apical impulse, the point of maximal impulse, hyperactivity of the precordium, and any palpable thrills. So as far as the apical impulse is concerned, palpation is usually superior to percussion in the detection of cardiomegaly. Its location diffuseness should be noted. Percussion in infants it's pretty inaccurate and doesn't add very much. And the apical impulse itself is normally at the 5th intercostal space in the midclavicular line after age 7. Before that age, it's in the 4th intercostal space just to the left of the midclavicular line. An apical impulse displaced laterally or downward suggests cardiac enlargement. Moving to the point of maximal impulse, it's helpful in determining whether the RV or LV is dominant. With RV dominance, the impulse is maximal at the lower left sternal border or over the xiphoid process. With LV dominance, the impulse is maximal at the apex. Normal newborns and infants have RV dominance and therefore more RV impulse than older children. If the impulse is more diffuse and slow rising, it's called a heave. If it's well localized and sharp rising, it's called a tap. Heaves are often associated with volume overload, and taps are associated with pressure overload. Hyperactive precordium. The presence of a hyperactive precordium characterizes heart disease with volume overload, like large left-right shunts, PDAs, VSDs, or heart disease with severe valvular regurgitation, like aortic insufficiency or mitral regurgitation. Thrills are a vibratory sensation that represents palpable manifestations of a loud, harsh murmur. Palpation for thrills is often of diagnostic value, and a thrill on the chest is felt better with the palm of the hand than with the tips of the fingers. However, the fingers are often used to feel a thrill in the suprasternal notch and also over the carotid arteries. Thrills at the upper left sternal border come from the pulmonary valve or pulmonary artery and are often present in pulmonary stenosis or PDAs. Thrills in the upper right sternal border are often of aortic origin and are seen in aortic stenosis, and thrills in the left lower sternal border are characteristic of VSDs. Thrills in the suprasternal notch suggest aortic stenosis, but it could also be found in pulmonary stenosis, PDAs, or coarctation. And the presence of a thrill over the carotid artery or arteries accompanied by a thrill in the suprasternal notch suggests disease of the aorta or aortic valve. An isolated thrill in one of the carotid arteries without a thrill in the suprasternal notch is considered a carotid bruit, and that's a normal finding in kids. Thrills in the intercostal spaces are found in older children with severe coarctation and extensive intercostal collaterals. So now we're going to turn to auscultation. We're going to talk about the heart rate and regularity, heart sounds, systolic and diastolic sounds, and heart murmurs. So, whereas the bell-type chest piece is better suited for detecting low-frequency sounds, the diaphragm selectively picks up high-frequency sounds. So we need to use both the bell and the diaphragm in our cardiac exams. So many of you have the two-sided Littmann stethoscopes with tunable technology, where each side acts as a bell and a diaphragm. So lightly pressing the stethoscope against the chest makes it a bell, and firm pressure makes it a diaphragm. Many students and even residents are not always aware of how their stethoscopes work, and I would recommend you get acquainted with that. So using only the diaphragm can result in missing some important low-frequency murmurs or sounds like a mid-systolic rumble, pulmonary regurgitation, or even a faint stills murmur. Also, you shouldn't limit your exam to the 4 traditional auscultatory areas. You want to make sure that you're listening to the axilla, the back, the neck, all of those things. So we need to avoid putting our stethoscopes on the chest and exclusively listening for murmurs. We need to systematically be aware of the different aspects of the exam so we don't miss anything. And like I said before, we're looking at heart rate and regularity, which should be known on every child. So very fast or very slow rates or an irregularity in the rhythm should be evaluated by an EKG and also a long rhythm strip. Regarding the heart sounds, the intensity and quality of the heart sounds, especially the second heart sound, has to be evaluated. Abnormalities of the first heart sound, or S1, and the presence of a third or fourth heart sound should be noted. You also want to pay attention to whether the heart sounds are muffled or not. If the heart sounds are muffled, then you're thinking that there's something between your stethoscope and the heart, and that could be a pericardial effusion. The next is systolic and diastolic sounds. So an ejection click in early systole, which is right after S1, is a clue that there's a semilunar valve problem, like a bicuspid valve or an abnormal pulmonary valve. A mid-systolic click makes you think of mitral valve prolapse. So heart murmurs should be evaluated in terms of intensity, timing, whether systolic or diastolic, the locations, transmission, and quality. Here we have a diagram of the various heart sounds. The first heart sound, S1, is associated with closure of the mitral and tricuspid valves. It's best heard at the apex or left lower sternal border, and splitting of S1 can also be seen in normal children. Abnormal wide splitting of S1 can be found with a right bundle branch or Ebstein's anomaly. Splitting of S1 needs to be differentiated from an ejection click or an S4. Ejection clicks, which are labeled here as EC, are more easily audible at the upper left sternal border in pulmonary stenosis. In bicuspid valves, the ejection click can be louder at the left lower sternal border or apex. Now, the second heart sound is in the upper left sternal border, which is another way for that is saying it's the pulmonary valve area, and that's of critical importance in pediatric cardiology. The S2 must be evaluated in terms of the degree of splitting and the intensity of the pulmonary closure component of the second heart sound, P2, in relation to the intensity of the aortic closure component of the second heart sound, A2. Although best heard with the diaphragm of a stethoscope, both components are readily audible with the bell. Abnormalities of splitting of the S2 and the intensity of the P2 are summarized in the next slide. So, splitting of S2. In every normal child, with the exception of occasional newborns, 2 components of the S2 should be audible at the upper left sternal border. The first is the A2, and the second is the P2. Both components are best heard at the pulmonary valve area, which is the upper left sternal border. The A2 is not the second heart sound at the aortic area. Rather, it's the first or aortic closure component of the second heart sound at the pulmonary area. So normal splitting of the S2. The degree of splitting of the S2 varies with respiration, increasing with inspiration and decreasing or becoming single with expiration. During inspiration, because of the greater negative intrathoracic pressure, there's an increase in the systemic venous return to the right side of the heart. This increased volume of blood in the right ventricle prolongs the duration of RV ejection, which delays the closure of the pulmonary valve, resulting in a wide splitting of the S2. And the absence of splitting, for example, like a single S2 or a widely split S2, indicates an abnormality. An abnormal splitting can be in the form of wide splitting, narrow splitting, a single S2, or even a paradoxical splitting of the S2, which is pretty rare. A widely split and fixed S2 is found in conditions that prolong the RV ejection time, or that shorten the LV ejection. So therefore, it's found in ASDs or partial anomalous pulmonary venous return. In other words, conditions in which the amount of blood ejected by the RV is increased, or volume overload. It can also be seen in pulmonary stenosis. So the valve stenosis prolongs the RV ejection time, and that's a pressure overload. It can also be seen in right bundle branch block, which is a delay in the electrical activation of the RV, and that delays the completion of RV ejection. It can also be seen in mitral regurgitation, which is a decreased forward output seen in this condition, which shortens the LV ejection time, causing aortic closure to occur earlier than normal. Number 2. A narrowly split S2 is found in conditions in which the pulmonary valve closes early, like pulmonary hypertension, or the aortic valve, or if the aortic valve closure is delayed, like aortic stenosis. A single S2 is found in situations like when one semilunar valve is present, like aortic or pulmonary atresia or persistent truncus. A single S2 can also be seen when the P2 is not audible, like transposition, tetralogy of Fallot, severe PS. It can be seen when aortic closure is delayed. An example of that is severe aortic stenosis. It can be seen when the P2 occurs early, like severe pulmonary hypertension. A paradoxically split S2 is found when the aortic closure follows the pulmonary closure, and therefore is seen when the LV ejection is greatly delayed, like severe aortic stenosis, left bundle branch block, sometimes Wolff-Parkinson-White pre-excitation. The intensity of the P2 is also important to note, and the relative intensity of P2 compared with the A2 has to be assessed in every child. In the pulmonary area, the A2 is usually louder than the P2, and you need to use your judgment as to normal intensity of the P2, and that is based on experience. The only way to do that is to listen to the hearts of as many normal children as you can. Abnormal intensity of the P2 suggests a pathologic condition. Increased intensity of the P2 compared with the A2 is found in pulmonary hypertension, and that is key. So if you hear a loud P2, you have to think about pulmonary hypertension. Decreased intensity of the P2 is found in conditions with decreased diastolic pressure of the PA, like severe pulmonary stenosis, tetralogy of Fallot, or tricuspid atresia. The S3 is a somewhat low-frequency sound in early diastole, and it's related to the rapid filling of the ventricle. It's best heard at the apex or left lower sternal border. It's commonly heard in normal children and young adults as well. A loud S3 is abnormal and is audible in conditions with dilated ventricles and decreased ventricular compliance, like a large VSD or congestive heart failure. The fourth heart sound is a relatively low-frequency sound of late diastole and is rare in infants and children. When present, it's always pathologic and is seen in conditions with decreased ventricular compliance or CHF. Gallop rhythm. A gallop rhythm is basically a rapid triple or quadruple rhythm resulting from the combination of a loud S3 with or without an S4 and tachycardia. It generally implies a pathologic condition and is commonly present in CHF. A summation gallop represents tachycardia and a superimposed S3 and S4. So let's talk about systolic and diastolic sounds. An ejection click or an ejection sound follows the S1 very closely and occurs at the onset of ventricular ejection. Therefore, it sounds like a splitting of the S1. So if you hear what sounds like a split S1 at the upper sternal border, it might actually be an ejection click. The pulmonary click is heard at the second and third left intercostal spaces and changes in intensity with respiration, being louder on expiration. The aortic click is best heard at the second right intercostal space, but it could be louder at the apex or mid-left sternal border. It usually doesn't change its intensity with respiration. The ejection click is most often associated with stenosis or an abnormality of the semilunar valves like PS or AS. A mid-systolic click, with or without a late systolic murmur, is heard at the apex in mitral valve prolapse, and a diastolic opening snap is rare in children, and it's audible at the apex or left lower sternal border. It occurs somewhat earlier than the S3 during diastole and originates from a stenosis of the AV valve, like in mitral stenosis. This is very, very rare in pediatrics that you're going to deal with the opening snap. So turning towards the extracardiac sounds, a pericardial friction rub is a grating to and fro sound produced by friction of the heart against the pericardium. And this sound is similar to a sandpaper rubbed on wood. This sound usually indicates pericarditis. The intensity of the rub varies with the phase of the cardiac cycle rather than the respiratory cycle. It can be louder when the patient leans forward, and it's important to note that a large accumulation of fluid, like a pericardial effusion, can result in disappearance of the rub. So if you have a patient with a friction rub one day and then the next day it's gone, it could represent a pericardial effusion. Okay, let's talk about heart murmurs, the grading scale of heart murmurs. So you want to analyze the murmur with regard to intensity, which is a 1 to 6 out of 6, the timing, which is whether it's systolic or diastolic, the location, the transmission, the quality. Quality is it musical, vibratory, blowing, etc. You really want to make sure you know the grading scale, because you may or may not realize that you're constantly being evaluated, and the way you're evaluated by other physicians is how you speak and how you write your notes. So if you write a poor note or you speak in without the proper medical terminology, people are going to have bad judgments about you. So it's very important to use the proper terminology. The grading scale, again, is 1 to 6 out of 6. 1, 2, and 3 do not have a thrill, and 4, 5, and 6 do have a thrill. 1, 2, and 3 are progressively louder. It's somewhat subjective. 4, 5, and 6, like I said, all have a thrill. A 4 out of 6 is loud and associated with a thrill, but if you take your stethoscope any part off the chest, you don't hear it any longer. A grade 5 out of 6 is there's a thrill and it's audible with the stethoscope about a 45-degree angle to the chest, and a 6 out of 6 is there's a thrill and the murmur is audible with the stethoscope 1 centimeter off the chest. Now, the intensity of the murmur can be influenced by the status of cardiac output. So any factor that increases the cardiac output, like fever, anemia, anxiety, exercise, intensifies any existing murmur, or can even produce a murmur that's not audible at basal conditions. So to kind of hammer this point home a little bit, I recently heard from a general pediatrician who called me up and said that she had a patient with a heart murmur, and I asked her, well, tell me about the heart murmur, and she responded by giving a pause, and I should have been aware that there was something going on if there was a pause, but there was a pretty long pause, and then she said it sounded like boom sh boom, boom sh boom, boom sh boom, and that was pretty alarming. So you're making judgments about people like that, fair or unfair. So all the more reason to use the correct medical terminology. So classification of heart murmurs are based on the timing of the heart murmur in relation to the S1 and S2. The heart murmur is classified into systolic, diastolic, and continuous. So systolic murmurs occur between S1 and S2, and most heart murmurs are systolic. A systolic ejection murmur begins after S1 and ends before S2. And this coincides with turbulent flow through the semilunar valves, and they occur in the setting of a couple of conditions, one being the flow of blood through a stenotic or deformed semilunar valve, like with aortic stenosis or pulmonary stenosis. It could be due to accelerated systolic flow through a normal semilunar valve, as seen in pregnancy, fever, anemia, thyrotoxicosis, and even innocent murmurs as well. Basically, the key thing here with these systolic ejection murmurs is that there's an interval between the S1 and the onset of the murmur that coincides with the isovolumic contraction period. So basically, there's S1, short pause, and then this crescendo decrescendo murmur. The intensity of the murmur increases towards the middle and then decreases towards during systole. The murmur usually ends before S2, like you can see in this slide. And the murmur can be short or long and is audible at the second left or second right intercostal space. Now let's contrast that with holosystolic murmurs. Holosystolic murmurs begin with S1 and may or may not go all the way to S2. The key thing that makes it a holosystolic murmur is that no gap exists between the S1 and the onset of the murmur. Analysis of the presence or absence of a gap between the S1 and the onset of the systolic murmur is of utmost importance in distinguishing between systolic ejection murmurs and holosystolic murmurs. So additionally, the intensity of holosystolic murmurs usually is plateau-shaped, like you can see from this diagram. Holosystolic murmurs are caused by the flow of blood from a chamber that's at higher pressure throughout systole than the receiving chamber, and they usually occur while the semilunar valves are closed. These murmurs are associated with only the following three conditions: VSDs, mitral regurgitation, and tricuspid regurgitation. None of these ordinarily occur at the base, that is the second left or right intercostal space. So the holosystolic murmurs live at the left lower and apex, the left lower sternal border and apex, and systolic ejection murmurs tend to live at the upper left and upper right sternal border. Now, in addition to the type of systolic murmur, the location of maximal intensity of the murmur is important when diagnosing with the heart murmur's origin. So you want to make sure you're listening at the upper left sternal border, upper right, lower left, and apex. You can remember APTM, where all politicians take money. And where they are, where the systolic murmur is, tells you generally what valve issue it is. So if it's at the upper left, systolic murmur at the upper left sternal border, you're thinking pulmonary stenosis. If it's the upper right sternal border, you're thinking aortic stenosis. If it's at the lower left sternal border, then you're thinking VSD or tricuspid regurgitation. If it's at the apex, then you're thinking mitral regurgitation. So a holosystolic murmur heard maximally at the lower left sternal border, like we said, would be most characterized by a VSD, although it technically could also be tricuspid regurgitation as well. The transmission of systolic murmurs from the site of maximal intensity can help determine the murmur's origin. So, for example, an apical systolic murmur that transmits well to the left axilla and lower back is characteristic of mitral regurgitation. But one that radiates to the upper right sternal border and the neck is more likely to originate in the aortic valve. A systolic ejection murmur at the base that transmits well to the neck is more likely to be aortic in origin, and one that transmits well to the back is more likely to be pulmonary in origin. The quality of systolic murmurs is important to know about. The systolic murmur agitation or of a VSD have a generally uniform high-pitched quality, which is often described as blowing, whereas systolic ejection murmurs of aortic stenosis or pulmonary stenosis have a rough or grating character. A common innocent heart murmur in children, which is best audible at the left lower sternal border and apex, has a characteristic vibratory or humming quality, and that's a Stills murmur. So next is diastolic murmurs. Diastolic murmurs can be characterized as early diastolic, mid diastolic, or late diastolic. For early diastolic murmurs, they occur immediately after the S2 and are caused by incompetence of the aortic root or pulmonary valve. Because the aorta is a high-pressure vessel, aortic regurgitation murmurs are high-pitched and best heard with the diaphragm of the stethoscope at the third left intercostal space. The aortic regurgitation murmur radiates well to the apex because the regurgitation is directed towards the apex. Bounding peripheral pulses can be associated if the aortic insufficiency is significant. And aortic regurgitation murmurs are associated with congenital bicuspid aortic valves. After an intervention for aortic stenosis, like a post-valvotomy or after balloon dilation, to be seen with a rheumatic heart disease as well, with aortic insufficiency. And another important point would be if you can hear it with a prolapsing aortic cusp through a VSD. So if you have a patient with a VSD and a systolic murmur, and then at some point later on, now they have a new diastolic murmur, you should be concerned that maybe now in addition to the irregular VSD, now we have the aortic valve prolapsing into the VSD, causing insufficiency, and that would be a surgical emergency. So if you have this patient with prolapse of the aortic valve with the defect, and it goes on for a while, then you're involved, instead of just a little VSD repair, now you have to replace the entire aortic valve because it's been damaged by the repetitive prolapse through the defect. Pulmonary regurgitation murmurs can also occur in diastole. They're usually medium pitched, but they can be high pitched if pulmonary hypertension is present. They're best heard at the third left intercostal space, and they radiate along the left sternal border. These murmurs are associated with postoperative tetralogy of Fallot because of surgically induced pulmonary insufficiency. They are associated with pulmonary hypertension, post-op pulmonary valvotomy, or after balloon valvuloplasty for pulmonary stenosis, and also if there's a mild deformity of the pulmonary valve. So mid-diastolic murmurs start with a loud S3 and are heard in early or mid-diastole, but are not temporally midway through diastole. These murmurs are always low-pitched and best heard with the bell of the stethoscope applied lightly to the chest. The murmurs are caused by turbulence caused by the mitral or tricuspid flow secondary to anatomic stenosis or relative stenosis of the valves. Mitral mid-diastolic murmurs are best heard at the apex and are often referred to as an apical rumble, although frequently they sound more like a hum than a rumble per se. These murmurs are associated with mitral stenosis or a large left-to-right shunt, VSD or PDA, which produces mitral stenosis secondary to a large flow across the normal-sized mitral valve. Probably more commonly is a tricuspid mid-diastolic murmur at the left lower sternal border, and they can be heard with an ASD, which is pretty common. It can also be heard with partial anomalous pulmonary venous return, TAPVR, endocardial cushion defect. All of these will result in the tricuspid mid-diastolic murmur because of relative tricuspid stenosis. Again, nothing is wrong with the tricuspid valve, but it's just a flow-related phenomenon. It bottlenecks at the tricuspid valve. Anatomic stenosis of the tricuspid valve is also associated with these murmurs, but it's very, very rare that you have just a organic tricuspid stenosis. The next type of diastolic murmur is presystolic or late diastolic murmur, and they're caused by flow through the AV valves during ventricular diastole, and they result from from an active atrial contraction that ejects blood into the ventricle rather than a passive pressure difference between the atrium and the ventricle. And these low-frequency murmurs occur late in diastole or just before the onset of systole, and they're found with anatomic stenosis of the mitral or tricuspid valve. So the last type of murmur that we're going to deal with here is continuous murmurs, and they begin in systole and continue without interruption through the S2 into all or part of diastole. They're caused by aortopulmonary or AV connections like PDA, an arteriovenous fistula. You can be caused by after you do a BT shunt, like a systemic to PA shunt. It can be caused rarely by a persistent truncus, and also disturbance in flow patterns in veins, like a venous hum. The disturbance of flow patterns in arteries can also result in these continuous murmurs, like coarctation or pulmonary stenosis. The murmur of a PDA has a machinery-like quality, becoming louder during systole. It's kind of crescendo during that period, peaks at the S2, and then diminishes in diastole, where it's a decrescendo. The murmur is maximally heard in the left infraclavicular area or along the upper left sternal border. With pulmonary hypertension, though, only the systolic portion can be heard, but it's a crescendic during systole. Venous hum is a common innocent murmur that's audible in the upright position in the infraclavicular region, unilaterally, bilaterally. It's usually heard better on the right side, though, and the murmur's intensity also changes with the positioning of the neck. So when the child lies supine, the murmur usually disappears. Less common continuous murmurs of severe coarctations can be heard over the intercostal collaterals as well. So the combination of a systolic ejection murmur and a diastolic murmur is also referred to as a to and fro murmur to distinguish it from a machinery-like continuous murmur. So, for example, if you have pulmonary stenosis and pulmonary insufficiency, we would call that a to and fro murmur as opposed to a continuous murmur. Okay, now let's talk about the different innocent heart murmurs. It's super common to have innocent heart murmurs in pediatric cardiology. In fact, more than 80% of children are going to have an innocent murmur at one time or another during their childhood. All innocent heart murmurs, as well as pathologic ones, are accentuated or brought out in a high output state. So that would be like a febrile illness. Or pregnancy. Probably the only way a physician can recognize these innocent heart murmurs is to become familiar with the more common forms of these murmurs, and that's only going to be done through practice. All innocent heart murmurs are classically associated with a normal EKG and chest X-ray, and when one or more of the following are present, the murmur is more likely to be pathologic and requires particular cardiac consultation. And those things are if they're symptomatic, if they have abnormal cardiac size or silhouette, if there's an abnormal EKG or diastolic murmur, if the murmur is particularly loud, like a grade 3 or greater, if there's cyanosis, if there's abnormally weak pulses, or any abnormal heart sound. Classic heart murmurs you can see in the chart, and I'll go over them one by one. The first is the classic vibratory Stills murmur, and this is going to be your most common innocent murmur. Most of them are detected between 3 and 6 years of age, but the murmur can also be present in neonates, infants, and adolescents. It's going to be maximally audible at the left mid-sternal border or over the mid-precordium, between the left lower sternal border and the apex. It's generally of low frequency and best heard with the bell of the stethoscope when the patient's in the supine position. The murmur is going to be systolic ejection type, grade 2 to 3 out of 6 in intensity, and it's not going to be accompanied by a thrill or an ejection click. It has a very distinctive quality, like a twanging string, buzzing, or vibratory musical characteristic. When I first heard that these murmurs were musical, I was always expecting to hear like a French horn or an oboe, but in reality, they don't sound like that at all. It's just like a buzzing kind of a sound, and after you've heard a couple, it'll make sense. The murmur is generally loudest in the supine position and often changes in character, pitch, and intensity with upright positioning. The vibratory quality may disappear, and the murmur may become softer when the bell is pressed harder, thereby proving its low frequency. The intensity of the murmur increases during febrile illness or excitement and after exercise and in anemic states. The murmur may also disappear briefly at the end of a maximal Valsalva maneuver. So the next murmur we're going to talk about is a pulmonary ejection murmur or pulmonary flow murmur. This is commonly heard in children between 8 and 14 years of age, but it's most frequent in adolescents. The murmur is maximally audible at the upper left sternal border, and this murmur is basically an exaggeration of the normal ejection vibrations within the pulmonary trunk. The murmur is exaggerated by the presence of epectus or kyphoscoliosis, and the murmur is systolic ejection in timing and slightly grating, not quite vibratory, but more like grating, with very little radiation. The intensity of the murmur is usually grade 1 to 3 out of 6. The S2 is going to be normal, and there's no associated thrill or ejection click. Now, the murmur itself does resemble the murmur of organic pulmonary artery stenosis, which can be seen with rubella, Williams, or Alagille. But the one way to know that this patient doesn't have those things is there's going to be nothing else going on with them. They're not syndromic or anything like that, and that would lead you more towards an innocent etiology. The next is going to be a venous hum. This is a very interesting murmur. The murmur of a venous hum is going to be commonly audible in children between the ages of 3 and 6 years of age. It originates from turbulence in the jugular venous system. There's a continuous murmur basically where the diastolic component is louder than the systolic component, and the murmur is maximally audible at the right or left infraclavicular and supraclavicular areas. Now, the venous hum is heard only in the upright position and disappears in the supine position. It also can be obliterated by rotating the head or by gently occluding the neck veins with the fingers. So that's one way to distinguish between the venous hum and the PDA, which is not going to change in position or by head turning. The pulmonary flow murmur of the newborn, this is a peripheral branch pulmonary artery stenosis type murmur. You're going to see, typically it's heard at, up to really 9 months of age. It shouldn't be heard by like around a year of age or later. You can hear it somewhat at the in the pulmonary area, the upper left sternal border, but it's going to translate prominently to the left or right axilla and back. So it's going to be, you can hear it a little bit in the pulmonary area, but it's going to be prominent in the left or right axilla and back. And that's your tip off that you're dealing with peripheral branch pulmonary artery stenosis. It's usually 1 to 2 to 6 in intensity. And if it goes away by a year of age, then it's completely normal. If not, then you want to refer them to cardiology. The last murmur we're going to talk about is the carotid bruit, and this is basically an early, it's basically a systolic ejection murmur, best heard over the supraclavicular area or the carotids. It's produced by turbulence in the brachiocephalic or carotid arteries, and the murmur is going to be a 2 to 3 out of 6 in intensity. A faint thrill can be palpable over the carotid arteries as well, and a bruit can be found in normal children of any age, really. Well, thank you very much for your attention, and best of luck on your exams.